Hello, my name is Janet and I'm a publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision, as well as for continuing professional development. Medicine's editorial board comprises of subject matter experts across all subspecialties of clinical internal medicine. As we publish each chapter in the journal, our chairman, Albert Farrow, will be interviewing the relevant board member and chatting to them about their specialty. We hope you enjoy them. To find out more about Medicine Journal, including how to subscribe, please visit www.medicinejournal.co.uk. You can also follow us on Twitter using the handle @MedicineUK1.
So, hello and welcome to the latest videocast from Medicine. I'm Albert Farrow. I'm the chairman of the editorial board, and it's my great pleasure to introduce Dr. Safa Al-Shamma, who's a gastroenterologist and hepatologist in Bournemouth. Safa, maybe I'll hand over to you, and you can say a little bit about yourself and your career path and what you do and so forth.
That's great. Thank you very much for inviting me. It's a great pleasure to be doing this podcast. As you say, I'm Safa Al-Shamma. I'm a gastroenterology and hepatology consultant. I work at University Hospitals Dorset, Bournemouth Hospital. Been there as a consultant for over 12 years now, I think. I suppose, I guess my path to it was a little bit going from north, edging southwards ever since. I graduated from Dundee University 20 plus years ago, and then I did my medical rotation in Dundee. And I moved southwards a little bit to Newcastle, where I did only a 2 or 3 month locum attachment in gastroenterology. And in fact, that's probably one of the key influences as to why I became a gastroenterologist. It was a very positive experience I had there, and in Dundee when I did gastro as well. I was quite lucky to work with Stuart McPherson and Colin Rees. Colin Rees is now the president-elect of the BSG, and ironically, I've recently taken on a role as secretary of the BSG.
The British Society of Gastroenterology, just to...
correct, that's right, yes, the British Society of Gastroenterology. And, I'll be responsible for doing the conference. After that brief stay at Newcastle, I moved down to the Mersey Deanery to do my formal gastroenterology training. And then I moved down to London for a year to do a King's College Fellowship in Liver Transplantation. And then I moved a little bit further down to Bournemouth, where I've been for the last 12 years or so, as I say, doing a gastroenterology and hepatology. So I think the positive experience in gastroenterology is one of the reasons I wanted to do it. I like medicine, and I want to do something that gives me an opportunity to do practical skills and procedures as well. And gastroenterology and hepatology certainly offer that. So I think it gives me the best of both worlds, really, and also have found time to be involved in things like the Royal College. So as a question writer, as a registrar, for the MRCP Part 1, then became on the board, and then I was secretary of the MRCP Part 1 board, which I still am, and I'm involved in the specialist exam, the SCEs, as well as the secretary of the exam board there. And I say that sort of links in nicely with my BSG roles. So I have a lot of interest in education and teaching, and I'm also the deputy director of medical education at my trust. So quite a lot to keep me busy.
It certainly sounds like it. And you, as you say, have been moving gradually southwards. So I don't think you can go much further south in the UK, at least.
Jersey, perhaps, or north of France, or something like that. But I need to brush up on my French.
Indeed. And it's a great pleasure to talk to you, not just because it's a pleasure to talk to you, Safa, but of course because the current issue of medicine is all about liver disorders. And so we thought it would be a good opportunity to have a little video cast on the subject. So maybe start off about saying a word or two about the assessment of liver disease, the identification, non-invasive assessment of liver disease. Do you want to say something about that?
Sure. I mean, I think, so there's absolutely no doubt that the burden of liver disease is significantly rising worldwide, and in particular in Western populations, driven by the ongoing problems with heavy alcohol consumption, but also the obesity, the epidemic of obesity, and the consequent fatty liver and everything else to go with that is causing significant problems with the liver. And often it's very much a silent disease in that people don't get symptoms until they present quite late, with complications, decompensation, cancer, whatever it is. I think over the years, there has certainly been a drive in which we try and identify more patients with liver disease at an earlier stage to be able to give them some brief advice and interventions, which can be effective, particularly with alcohol consumption advice, and healthy lifestyle advice, which is not always guaranteed to succeed, but at least you have a better chance. So the sort of things that we're doing is simple things. And in the old days, we used to rely on liver biopsies to diagnose and exclude advanced liver disease and sometimes imaging. But now we're using more intelligent ways of blood tests, simple markers, simple day-to-day blood tests like AST and ALT to do calculations such as the FIB4, the fibrosis 4 basically. And if it's above certain thresholds, then they should be referred for further assessment. If it's less than that, then it's unlikely to have advanced liver disease. We're also using non-invasive elastography, which gives us an idea of how stiff the liver is, and it gives us an understanding of that, whether they could or may not have advanced liver disease. So these are ways in which we can make it easier for primary care to be able to identify the patients that they need to be worried about and refer, and most of the other patients who can remain in primary care but be given the relevant lifestyle advice to help reduce the risk of progression of liver disease. So that's one of the things that has changed, perhaps over the last decade or so, where we're much more assertive in our use of these markers and those non-invasive ways of assessing things. There's also more of a drive towards intelligent testing, whereby if somebody's blood tests are sent and they show an abnormal parameter in the liver test, it reflexes, the lab reflexly performs further additional testing to assess whether they could have advanced liver disease automatically, rather than going back to the GP who looks at the result, recalls the patient, gets them to have more blood tests, and so on. So it makes the process more efficient, more seamless, more quick to reduce the risk of missing out on identifying these potential patients with advanced liver disease.
Gosh. You kind of mentioned that we're sort of picking up patients with liver disease at an earlier stage, and quite often with incidental, as an incidental finding, maybe. I know in my hypertension clinic, for example, I'm often doing full biochemistry to check for renal function and other predisposing factors for hypertension. And as part of it, liver function tests come back and they're abnormal, and then one's in a bit of a quandary as to what to do there, because it's not what they were referred for, and how should they be investigated further. Do you have any sort of advice in that situation? You do a liver function test for an unrelated reason, they come back abnormal, let's say a raised transaminase, ALT. Well, what should the practitioner do in that situation?
I think that's a very common scenario in primary and secondary care. The default is often to ignore it, but I think you can be smarter about it, which is to do the FIB4 calculation, which is a very easy calculation. Any online calculator could do it on an app on the phone, and that will just need an AST, ALT, platelet count, and patient age. Mm-hmm. And then that will give you certain cutoffs based on the age, and slightly different to different areas, what the guidelines are. And if they're below that cutoff, they can be reassured they're unlikely to have advanced liver disease. If it's above a certain cutoff, then that's a trigger to be referred either to secondary care, or actually there's an expanding service in primary care of being able to do fibroscans. So whereby GPs can request the fibroscan, which is a more, I suppose, a more definitive way of assessing for the degree of fibrosis in the liver. And again, if it excludes anything advanced, they can be discharged. If it shows advanced disease, then that's the trigger to go on to secondary care. I suppose the abnormal liver test quite often is a surrogate marker of something else going on, even if there isn't advanced liver disease, but having the fatty liver, we know, is a sign that, you know, metabolically you're unhealthy, shall we say, and that means you're increased risk of developing diabetes in future. You may have other elements of metabolic syndrome, high blood pressure, with it the increased risk of strokes, heart disease, and so on and so forth. So even if you don't have advanced liver disease, having a degree of fatty liver does indicate that metabolically all is not right, and you know, underlying cause needs to be addressed one way or another.
So fatty liver you've sort of mentioned, and sort of maybe brings us on to talk a little bit about that, because I think it's fairly common, isn't it? And just maybe tell us a little bit more about what it is, its causation, and what we should be doing.
Sure. So fatty liver is certainly it's a worldwide phenomenon now. It's not just of the Western population, but it's certainly higher. It's clearly directly linked to the obesity epidemic. There's no doubt about that. As the name suggests, it's simply an infiltration of fat in the liver, usually associated with obesity, but a percentage of people, about up to 20% in the literature, would suggest that people can be lean and have fatty liver. It can be due to a variety of causes as well. You know, bad diets, high carbohydrate, sugar content, alcohol consumption can certainly drive fatty liver. And often there is a combination, of multifactorial rather than one thing in particular. And as I say, it is associated with the metabolic syndrome. In the majority of people, it doesn't actually cause liver problems per se. So perhaps up to 25 or even more of the population will have some degree of fatty liver. Depends on which study you look at, anywhere from 20 to 40%. So it's very, very common. But only a certain percentage will get NASH, which is the steatohepatitis. And it's the inflammation that goes with the fatty liver. And when you have the NASH, then you're likely to then develop fibrosis and scarring, which can progress to cirrhosis and the associated complications to go with it. So we can't realistically identify everybody in a population with NAFLD. And at the moment, we don't have very good ways of distinguishing between NAFLD, which is the fatty liver, and NASH, which is the steatohepatitis, the inflammation. Although blood markers are in development, that will hopefully help guide us as to which patients we need to focus more of our attention on from a liver point of view. And in terms of treatment for NAFLD and NASH, unfortunately, at the moment, as things currently stand at this exact moment, there are no approved in the UK. It is about lifestyle changes. There's no doubt lifestyle changes, as again, the reduction in carbohydrates and sugars, reducing caloric intake, increasing exercise and physical activity, all will help reduce the fatty liver. But there's progress being made, and that's a great thing about it. There's definite progress being made, and we may well have one or two treatments in the coming few years, and there's different mechanisms of action whereby the new treatments will be targeting. Vitamin E was one of the drugs that was touted in the past, and the PIVNS trial many years ago suggested maybe beneficial, but it doesn't really come into play because of the potential side effects with it. The pioglitazone was again effective in the PIVNS trial, but they've fallen on the wayside, the PPR, that particular one type, because of the side effects. But there are new treatments are on the horizon. So one that's really advanced trials is a drug called Ocaliva, which is a farnesoid X receptor agonist. That one is approved for PBC, primary biliary cholangitis. The data for it in fatty liver and NASH has perhaps been a bit slow to prove efficacy, and there's been some the trials have not quite reached the statistical strength that one would want for it to be approved, but hopefully we think it might become approved in the not so distant future. But other mechanisms of action, the SGLT2s may have some benefit. So they're obviously the diabetic agents, and perhaps for weight loss. And the GLP-1s are certainly looking as though they could get a license for fatty liver, whether that's through their weight loss benefits or whether that's through a different additional mechanism of action that helps reduce the fatty liver and the steatohepatitis. I can't be absolutely certain, but it may well, some data with semaglutide is coming up that may be beneficial in fatty liver, may get a license and approval for that. But word of caution, the data doesn't suggest it reverses fibrosis, which is one of the key things about why people worsen under fatty liver. There are other mechanisms of actions, thyromimetics, for example, which sort of stimulate thyroid receptors in the liver, may have a potential role in future. Other PPAR sort of target agents, that being elfibranor, for example, or one of them that may get a license. But again, it's quite tricky with fatty liver to prove the benefit because it is a relatively slow progressive disease, and you need to wait for endpoint and need biopsies. It's quite difficult to recruit to these trials, and that's part of the reason why we struggled, unlike with viral hepatitis, whereby it's a much easier way in which you've got a virus, you give them a treatment, it's either cleared or it's not cleared, and you can say, this is absolute certain, this has worked, it hasn't worked.
Well, I think you've outlined the difficulties in progressing these treatments for NASH very well. So it'd be interesting to see how things develop in that regard. And you mentioned viral hepatitis. When I was a trainee, there were no treatments available, and I think that whole field has transformed, really, hasn't it? First with hepatitis C, but now with others as well. Perhaps you could tell us a bit about that.
I think absolutely, in contradistinction to fatty liver, where we're still grappling with what's the right treatment and what medication we will. Viral hepatitis, specifically hepatitis C, has had huge success, an absolute field change in it, from being just over a decade ago, let's say, a disease that's difficult to treat. We had treatments for it. And hepatitis C was first identified in the late 80s, and it was called none A, none B. Why they never jumped and just called it C straight away, I still don't know to this day. But it is very strange. So they had this hepatitis C, and obviously it was difficult culturing it and growing it in the lab, which is part of the reason why it's taken so long to get treatments. But once they're able to do so more effectively, you can then identify all the different targets for treatment of it. And about a decade ago, give or take, there were lots of new agents coming through. Prior to that, we just had interferon injections with ribavirin, horrible side effects, cure rates 40-50% if you're lucky. We had to be in it for a year, and it was a miserable year, and lots of people get lots of side effects. They couldn't finish this course of treatment, and even some people died as a result of treatment. Then the DAAs, direct acting antivirals, came through, and at one stage it was a bit like with the HIV field, when there were tons of medication, 20 to 30 odd agents in development or being developed, if not more than that, all really good efficacy. But then, fortunately, about 3 or 4 really led the way, and they've been established treatments that we have, and they're what we call pangenotypic. So there's at least 6 different genotypes of hepatitis C, and the drugs are, some of the drugs are effective against all of them. They're effective in people who have advanced liver disease or cirrhosis. They're effective in people who've previously been treated. You know, one of the earliest super effective agents was Harvoni, which is a combination of sofosbuvir and the diffusvir, and that was giving cure rates for chronic hepatitis C of 95% plus. I mean, there's virtually no chronic illness where you can get cure rates of over 90% on a consistent basis. You know, even H. pylori, you can't cure that at 95% plus with antibiotics. So they're highly effective 8 to 12 week courses of treatment that are generally very, very well tolerated with a very clean side effect profile. So that's been a huge sea change in the treatment. So from being unable to cure it to being very easily able to cure it. And actually the focus has changed. The drugs were, of course, very, very expensive at the beginning. But through commissioning and with time, the price has gradually come back, that for most patients, as long as they're able to as long as they have a life expectancy more than 6 to 12 months, they should be suitable for treatment. And as I say, the cure rate is high, and now the focus is really on trying to identify the really hard to treat groups of patients to get the treatment delivered to them, so that we can eradicate the virus. So we're doing it in ways in which we test them the same day as give them the treatment as best as we can. Literally, it's changed so enormously.
Mm-hmm. Amazing. And what about the other sort of viral hepatitis?
So yes, so hepatitis B and D, the two other main chronic viruses. Well, for hepatitis B, we've had the nukes, entecavir or tenofovir, most commonly tenofovir, and they're good at suppressing the virus to undetectable levels, but it's not a functional cure that we would be wanting, where we want to see the loss of the surface antigen. And there has been some progress with that over the last few years, with newer agents being developed. And that's still work in progress, really. At the moment, we're keeping people indefinitely or lifelong on tenofovir, for example. Although some data suggests after 2 or 3 years, you could try stopping it and seeing what happens. And ironically and paradoxically, they may be more likely to lose their surface antigen if you withdraw the drugs compared to just staying on it. Part of the problem is that the innate immune system is quite weakened and tired and exhausted with chronic hepatitis B, so it doesn't quite fight the virus as effectively. And some of the treatments that are potentially going to be effective for hepatitis B act on stimulating the innate immune system to sort of try and fight the virus. So that's a potential future mechanism of action that we can use. The other way could be by suppressing the virus in different ways and suppressing the replication. And there are different mechanisms of actions that are upcoming as well, such as entry inhibitors that happen, and also RNA interference molecules as well, that sense and oligosense sort of interference molecules that are these antisense ones are coming, and they again will affect the way the virus replicates and hopefully with combination therapies help cure it. And there's a big problem with hepatitis D, Delta, that is an aggressive form of chronic viral hepatitis that will lead to cirrhosis and decompensation in a significant proportion. And again, we don't have effective treatments apart from interferon. And again, some of these new medications are coming. Bulevirtide is something that's been recently approved, and that's one of the agents that we're hopefully going to get UK approval, but there will be other mechanism of action that will hopefully complement that to try and eradicate hepatitis D, but we're not quite there yet.
But it sounds like advances are really happening in that area.
Correct. There are absolute advances. I would think that in the coming decade, we would certainly be able to find more treatments that will offer functional cure for hepatitis B. And of course, if you cure hepatitis B, then by definition, you would cure hepatitis D with it, because the Delta virus needs the surface antigen to replicate. So if you eradicate the surface antigen and the hepatitis B, then you should, by definition, get rid of the Delta as well at the same time.
What about hepatocellular cancer? Is there anything new in that area?
So hepatocellular cancer is definitely on the rise. Viral hepatitis was the main cause before, but now it's also the fatty liver and alcohol liver disease. And in fact, hepatocellular cancer is one of the biggest indications for liver transplant. So before, it used to be hepatitis C. Now, hepatitis C is a very unusual indication for liver transplantation, and that's in the space of under a decade. So that's a huge change. For hepatocellular cancer, the current treatment paradigm is hugely different and is undergoing change. So if we look back 15 years to 10 years ago, we only had, for systemic therapy, we only had sorafenib. We've had local regional therapies. We can ablate them, so burn them. We can do resection. We can do local regional therapies such as TACE, transarterial chemoembolization, and more recently, SIRT has become approved, so that's internal radiotherapy. Future-wise, there's moves towards improving access to SIRT, There's SBRT, so stereotactic body radiotherapy, that can give you really localized, and that can be effective, but it's only really currently in very specialist centers, but hopefully with time that will expand. And then, of course, there will still be a proportion of patients who have extrahepatic disease, so they've got metastatic disease, in whom local regional therapy concentrated on the liver isn't going to be enough to treat the disease because they've got it in the lymph nodes or the bones or the lungs or whatever, and they need systemic therapy. And sorafenib, which is a VEGF, so vascular endothelial growth factor inhibitor, that's been around for, I'd say, 15 years, extends survival by about 3 months, give or take. Does have quite an unpleasant side effect profile. And that was our mainstay until the last few years, when we've developed newer agents as potential other first lines, such as lenvatinib, which has a cleaner profile, regorafenib, which can also be used in people who progress in sorafenib. But the immunotherapy has also come into its own, and there certainly is already one agent in combination, so atezolizumab with bevacizumab, combination therapy. Now that's approved as first-line treatment for people with good performance status who are not suitable for local regional therapy. And the other immunotherapies are potentially likely to come into play as well in future. There's trials and studies with nivolumab and the other newer agents as well. So there's likely going to be more immunotherapies that we can use for hepatocellular cancer in conjunction with a VEGF, for example, or even in conjunction with local regional therapy. So again, we've improved the survival of patients with advanced HCC from perhaps a median of 12 months before, now to a median of 36 months easily, and potentially longer going forward. Immunotherapy hasn't been a game changer quite the same as it was, let's say, with melanoma, but it certainly has added some significant benefit in hepatocellular cancer as well.
Still some pretty remarkable extension of life.
Multiple agents, absolutely. And actually, for future, we perhaps also need to start thinking more about how do we better screen for hepatocellular cancer, because there's a huge burden of it. The screening itself is quite costly, because everybody with cirrhosis who's suitable for treatment, we would offer them HCC surveillance with ultrasound on a 6-month basis. That's quite labor intensive, with a relatively low pickup rate and highish miss rate, because ultrasound is not more suitable for a lot of people who had the NASH risk factors and body habitus. So are there ways in which we could use artificial intelligence and models in which we can predict the higher risk patients who develop hepatocellular cancer, target our screening more for patients who are likely to develop hepatocellular cancer in the coming 3 to 5 years? So that's another potential advancement in the field that we're likely to see over the coming few years.
Maybe we might just sort of turn briefly to liver transplantation, which you alluded to, and the fact that there's much less hepatitis C now that goes on to liver transplantation, but there are other reasons, including hepatocellular carcinoma and others as well. What is the current state in the UK? Is there availability of livers for donation? Are there any barriers? What are the barriers at the moment?
Sure. So there's undoubtedly a mismatch. There still is a mismatch between the number of people who need a liver transplant and the available organs that have been donated that are suitable to be transplanted. There's no doubt that the rate of liver transplantation has been increasing year on year because of increased need, but increased availability. But of course, the COVID pandemic put a real stop on that. And that was a major shock because, of course, ITUs were full of patients with COVID, and lots of it had to be suspended temporarily, and that caused a lot of harm for that period. Now we're recovering, and the services are getting back to some form of normality. I guess one of the main things is how do you increase the donor pool, and how do you improve the organs that are being donated, how you protect them. There's been a change in the consenting process for the donation. That has had relatively small impact, but it's adds something. But there's been more progress and development of ways in which we can protect the organ that's been donated. So one of the big problems is the ischemia time. So once they've been explanted from the donor and the time it takes to be transplanted into the recipient. And that can be a number of hours. And in that time, the organ is obviously ischemic. You keep it cold to try and protect it. But there's that cold ischemia. The longer that is, the more likely that post-transplant you run into problems like cholangiopathy and so on, where there's bile duct damage. So there's now much better and effective ways of trying to perfuse the organs, keep the organs perfused, cold perfusion, to try and buy as much time as possible to get the organ to the recipient and to keep it as healthy as possible, so that when it is transplanted, it works more immediately, more effectively, and it reduces the risk of long-term complications. So that's one of the sort of main things that's happening. And then that means hopefully more what we call marginal livers can be used and donated, expanding the number of available livers to try and get as many recipients transplanted as effectively as possible.
Well, it certainly sounds like there's advances in a lot of areas in hepatology. It's been great to sort of have a quick tour of these with you, Safa. I guess I'll finish off just by asking you a very general question. Where do you think, in 10 years' time, what will be the changes that will be seen in the liver field, do you think? Where will we be in 10 years' time?
Okay,
so obviously.
Yes, and of course. I think there's going to be, as I was sort of alluding to earlier, there's going to be a greater emphasis on trying to identify liver disease earlier. I think there's going to be more of a drive and push to manage liver disease in primary care, so out of secondary care, out of the hospitals. And that would be important if we are identifying more patients. I think public health is clearly going to have an important role in trying to reduce the burden of liver disease, whether it's alcohol, whether it's obesity, whether it's identifying viral hepatitis early because we can cure it. So I think these factors will certainly be coming to play. Hopefully in 10 years, we'll have some effective treatments for fatty liver and NASH. That will reduce that side of things. I'm hopeful we could have perhaps some effective treatments or policy for alcohol to maybe reduce the alcohol consumption burden. Less hopeful on that one. And I think the field of hepatocellular cancer is likely to continue to evolve further, and we might have even more effective therapies there. Transplantation, I think, will be expanded to include people with other types of cancer, not just hepatocellular cancer. So cholangiocarcinomas, for example, will potentially be offered transplant, and even colorectal metastases, single colorectal metastases may be offered liver transplantation as well. So, the cancer side of things may also continue to evolve, as it has done quite a lot in the last few years over a whole spectrum of different cancers.
Excellent. Well, thank you very much, Safa. I think we've sort of taken up a fair bit of time, but I think we've explored some interesting areas in this video cast. Thank you very much. It's been a real pleasure talking to you. And just for the watchers and listeners to this, just again to say that if you want to consult the Medicine Journal, you will have this month, which we're in May at the moment, is the issue on liver disorders, and you can read more about some of what we've been talking about today. So, Safa, thank you very much once again.
My absolute pleasure. Thank you very much.